Hello and good evening everyone. Today I'll be talking about diabetes mellitus and Ramadan, how we can manage certain medications which are being used for diabetes mellitus during this fasting period and how we can maintain a normal glycemic status, especially in those patients who are suffering from overtly type 2 diabetes mellitus. So as we all know that type 2 diabetes mellitus is not a single entity disease. It's a heterogeneous group of disease that is characterized by hyperglycemia along with the different combinations of insulin resistance and or insulin deficiency. And a large number of patients are suffering from diabetes mellitus and need certain form of medications, be it in oral hypoglycemic therapy or insulin therapy. Fasting is an important part of many religions across the globe. We all know about it. The duration of fast per day, the number of days and the type of fast varies greatly across several religious groups. Healthcare professionals treating people with diabetes need to understand the impact of the religious and cultural practices of their patients on their diabetes. Consequently, this can improve the skills of the healthcare physician and the safety of the people with diabetes wishing to fast. Because fasting has different kind of effect on human body. At the same time, if you are taking some drugs that can lower your blood glucose level, and if you are not taking enough food, then you might be exposed to the risk of hypoglycemia. Along with that, if you don't take this kind of drugs, your blood sugar may be very high. So these all actually affect the overall status of the glycemic status for a patient who are suffering from diabetes mellitus. And therefore, it is very much needed to understand the basic pathophysiology and how we can go with that. So coming to Ramadan and diabetes, we all know that one of the first pillars of Islam is fasting for a month from dawn to sunset. This fasting involves refrain from intake of food, liquids, even oral medications. Religious fasting is not intended to create excessive hardship, however, and ill individuals are exempt from fasting. However, many Muslims with diabetes choose to fast during Ramadan for religious, cultural, or social reasons. Like in Hindu group also, even in elderly people, they want to fast during their Durgastami Puja or Navratri. In Jain, in Sikh, in any other religious groups where the fasting is there, the people with older individual, even Sikh individuals tend to uh, fast, tend to do this kind of activities to remain in the religious group. And this comes from their mind, this comes from their body, this comes from their soul. So this has become a very imperative for their life. So you cannot say that you should not do it. But if anybody is wishing to do this kind of fasting, then this fasting is definitely going to impact their lives in several ways. Worldwide, Muslim with diabetes, our population is approximately more than 148 millions. And patients with diabetes worldwide may fast during Ramadan. Depending on the season and geographical location, it has been seen that the duration of fast will vary from 12 to 24 hours. This is approximately an estimate. So I'm giving you a case scenario to understand this kind of practices. A 48 years female who works as a teacher, of 70 kg weight, BMI of 27 kg per meter square, blood pressure of 130 by 74 millimeter of mercury, was diagnosed with diabetes 6 years ago. She has been taking medications. She has background diabetic retinopathy. However, her renal function is normal. She is currently on metformin and sulfonylurea. She attends the clinic before Ramadan and her latest HbA1c is 8.1%. She experienced symptoms of hypoglycemia twice during busy days at work. She always fasted Ramadan and she is very keen to fast and she asked for your advice. So what would you say? Because you can easily understand that her glycemic status has not been well controlled because HbA1c is quite high. At the same time, she has experienced the symptoms of hypoglycemia. That means her blood glucose level went below the normal level. So the question comes to fast or not to fast. So before answering these questions, you have to understand that level of risk are great. If she chooses to fast, then what are the risks? Second question comes is that how to assess that risk. And third one is that how to minimize her risk if she fasts for Ramadan. So these are the questions that need to be answered before we can directly come to the conclusion whether she will going for fast or not. So the majority of Muslims with type 2 diabetes mellitus fast every day during Ramadan. There is no denial of the facts. And Ramadan Prospective study, which is also included in the CREED registry, CREED study, has shown that the type 1 Ramadan Prospective study, the type 1 diabetes mellitus, the percentage of this everyday fasting is 48.1%, 48.5%. In cases of type 2, it is 57.3%, and almost 56.7% of the patients fasted every day, and more than 15 days at a stretch, but not regularly. The percentage overall is 32.5%. So a large number of patients fast every day, and almost one third of the patients fast alternate day for a cumulative period of more than 15 days. What happens during that period, it also changes the sleep patterns, and sleep patterns changes during Ramadan. If we compare the sleep patterns, the sleep and meal patterns during Ramadan and non-Ramadan periods, then you will understand that it has been seen that physiological changes are most marked in countries at higher altitude with more daylight hours. Sleeping patterns are often altered during this period. The impact of Ramadan on sleep includes decreased total sleep time, delayed sleep, decreased sleep period time, decreased REM sleep duration, decreased proportion of REM sleep, and increased proportion of non-REM sleep. So this rapid eye movement and non-rapid eye movement of sleep has been altered significantly. What happens to the blood glucose levels? It has been seen that the blood glucose levels rise rapidly after the iftar. That is when they are going to take food after the fasting. And in that period, the blood glucose shoots up very high. And in the CGM study, there was no difference in number of glycemic events during Ramadan compared with pre-Ramadan. Major inter and intra-individual variability in CGM profiles are observed. Rapid rise in blood glucose after iftar was recorded. And this high glycemic shoot is very dangerous even in those patients who are not actually diabetic. So these are the consequences of after taking a heavy meal after a prolonged period of fasting. So key risks associated with Ramadan are basically hypoglycemia, that is less than 70 mg per dl, hyperglycemia, that is very high glucose, more than 300 mg per dl, the prevalence of diabetic ketoacidosis. We all know about diabetic ketoacidosis, that patients need to be admitted in the hospital and to be treated with the insulin and other metabolic parameters to be corrected. Dehydration and thrombosis, these are the overall risks. In time of summer, fasting periods can last up to 20 hours per day and are often undertaken in hot and humid conditions, which can exacerbate this risk very much. So these are the risks that you have to assess before going for prolonged fasting. Type 2 DM confirmed hyperglycemia cases as per CREED study. It was that the patients reporting hypoglycemia is 5.4% versus 8.8%. So diabetes and Ramadan international perspective study was also done, and hypoglycemia before and during Ramadan among type 2 diabetic patients were studied clearly, and the CREED registry were also taken into consideration, and it showed that the confirmed hypoglycemia was approximately 4.9%, that is 4 weeks before Ramadan, and during Ramadan it went up to 9.8% with a statistical significant value. So that means a large number of patients had incidence of hypoglycemia, and in form of severe hypoglycemia, which was 4 weeks before on 0.2%, in those group of patients, they went up to 0.8%. So severe hypoglycemia was not very frequent. However, episodes of confirmed hypoglycemia was very frequent with a statistically significant value. And in the CREED registry also, we did find the patients reporting hypoglycemia also went up from 5.4 to 8.8%. The incidence of hypoglycemia during this period for individuals who had no episodes of hypoglycemia before, that has been shown in the black bars, and for individuals who did have episodes of hypoglycemia before, that is the gray bar, has been shown in. This study was done by Abdul Jabbar et al. And was published in Diabetes Research and Clinical Practice in 2017. You can easily see that Asia, Middle East, North Africa, Europe, and as a total, the incidence of this, which has been shown in the black bar, the percentage of individuals 2.7, 3.3, 8.7, 5.3, and 5.0 compared to the gray bar. So this is now quite understandable that the incidence of hypoglycemia is quite high. Coming to diabetic ketoacidosis, which is a very dangerous complication of this prolonged fasting in this group of patients. So, a prospective multi-country observational trial to compare the incidences of diabetic ketoacidosis in the month of Ramadan, the preceding month and the following month were done. And the conclusion of the study was that in concordance with DKR1, DKR International showed higher rates of DKA during Ramadan when compared to preceding lunar month. And in Sawal, however, the rates of DK admission were higher than the average monthly DK admissions. The duration of acidosis was longer in Ramadan group and positively correlated with duration of diabetes. Many patients did not receive structured education about diabetes and fasting Ramadan. And this study calls for formal pre-Ramadan education and enforces the need for advice against fasting in patients who already experienced diabetic ketoacidosis in the months preceding Ramadan. So this is the very important findings that this study showed us too. Coming to diabetes and research clinical practice, the practical guidelines that has been formed with several kinds of studies, and this study, the invited review which was published in the Elsevier Journal, clearly said about that you should be very much concerned about doing fasting if you have past history of diabetic ketoacidosis. So healthcare physicians and religious leaders must deliver the same message regarding which patients should not fast. And unification should be there from the healthcare physician as well as the religious leader. Not all patients will consult HCPs prior to fasting. Some patients prefer to discuss fasting with the local imam rather than the physician. And disparity has existed between medical and religious advice on diabetes and Ramadan fasting. However, the unification is very much essential to prevent catastrophic events. Both diabetes and patient characteristic influence the risk of Ramadan fasting. Safety of fasting is paramount, and various elements should be considered when quantifying the risk of such patients. Risk quantification must be carried out on an individual basis for each patient looking to fast. The care given must be personalized according to the patient's specific circumstances. Factors for risk quantification are type of diabetes, patient medications, especially those group of medications which lower the blood sugar level, and patient must not fast for a very prolonged period of time, or you have to change the medication dosage, or you have to change the medication time. Individualized hypoglycemic risk, presence of complication, comorbidities like renal complications, which are in this group of patients are more prone to develop hypoglycemic attack. Individual social work and circumstances, if somebody is working as a whole day and not taking at the same time doing exercise, then the risk of hypoglycemia is much more. And previous experience of Ramadan, how well he or she could tolerate the previous Ramadan. These are one of the very important parameters that we have to look upon before going for fast. Pre-Ramadan diabetes education should be based on several areas. Again, the risk quantification, blood glucose monitoring, fluid and dietary advice, exercise advice, medication adjustment according to the day and night time, when to break the fast. This is a very important thing that you have to assess. And all individuals seeking to fast should attend a pre-Ramadan visit 6 to 8 weeks before Ramadan so that the risk quantification could be done, the detailed medical history, aspects of diabetes and ability to self-manage, presence of comorbidities, the individual's ability to self-manage diabetes, the individual's prior experience in managing diabetes during Ramadan fasting, and other aspects which might increase the risk of fasting should be assessed properly. Frequency of self-monitoring of blood glucose needs to be guided by risk stratification and individualized treatment plan. All individuals should break their fast if blood glucose less than 70 mg per dl. Recheck within 1 hour if blood glucose is 70 to 90, then you have to take more. Blood glucose level more than 300, that is, patients need to be on medications. Symptoms of hypoglycemia, hyperglycemia, dehydration or acute illness may occur. You have to be concerned about this fact. And post-Ramadan assessment is also necessary. What are the things that we followed up in post-Ramadan period? Eid al-Fitr, a 3-day festival, marks the end of Ramadan, and individuals with type 2 diabetes mellitus should be made aware of the risk of overindulgence during this time. A post-Ramadan follow-up meeting with healthcare physician is advisable in order to discuss medication and regimen readjustment and assess how the patients handle fasting during Ramadan. It should be stressed to the patient that fasting safely 1 year does not guarantee that they can fast safely the next or make them a low risk for the Ramadan due to the progressive nature of the disease, because with the time changes, the medication history changes, the patient compliance changes, and overall outcome also changes. So impact of daytime hypoglycemia, where was much worried about hypoglycemia, it has been seen that the risk is very high. And especially in the daytime, the risk is very high because they are not taking food for a very prolonged period of time. So at that time of period, and if somebody is taking some medications which lower the blood glucose, so in the noon time, the risk is very high. So individualization of the treatment is the key to the success of management of diabetes during this period. And despite the risk, many people with diabetes will fast. Most patients with type 2 diabetes can do so safely as long as medical advice is sought and followed prior to and during fasting. Before assessment, risk assessment, individualized management plan, provide advice on self-management. During, proper care, nutritional plan, medication adjustment according to the time, and self-monitoring of blood glucose very much essential. And post-Ramadan, follow-up, discuss medication, readjustment, and again checking with the blood glucose parameters. So impact of patient education on hypoglycemic events has shown that you can decrease these episodes significantly. Patients are advised to monitor their blood glucose several times during the day, especially in those group of patients whose blood glucose is not at control. The level should be checked at any time when symptoms of hypoglycemia are recognized. The 10 principles are: divide an adequate amount of calories between the daytime, between the night time, whenever you are taking the food during iftar, and if necessary, 1 or 2 snacks. Meals should be balanced with 40 to 50% carbohydrate, with low GI source, 20 to 30% protein, and 30 to 35% fat. Design meals using the Ramadan plate method. Avoid sugar-heavy desserts. Low GI, high fiber carbohydrate are preferable. Hydration should be maintained between meals by drinking water and non-sweetened beverages. Take suhoor as late as possible. Adequate protein and fat should be consumed at suhoor to induce satiety. Iftar should begin with water to dehydrate and 1 to 3 dates to raise blood glucose. Low calorie intake, 100 to 200 calories such as fruits, nuts, or vegetables may be consumed between meals. So these are the few of the important aspects that you can follow. Diabetes and Ramadan international prospective studies has shown that the anti-diabetic medication doses change for Ramadan, no change in the overall was approximately 50%. Oral anti-diabetic changes was more frequently seen because these are more prone to develop hypoglycemia. Insulin changes were significantly seen because in the daytime insulin, if you are taking before breakfast and not taking food for a very prolonged period of time, the risk of hyperglycemia is very high. So that changes need to be there. And overall other kind of medications changes are quite less. So all patients should schedule a visit with the physician 6 to 8 weeks before Ramadan. The risk stratification, self-monitoring should be very much important and should be there continuously. When to break the fast, when to exercise, it's very important and they should understand. Fluids and meal planning and medication adjustment is one of the most important parameters to control hypoglycemia. After proper assessment, detailed history, medication history, what kind of medications they are taking, and exact timing is very much important. If they are allowed to fast, then moderate to low risk group, then frequency of self-monitoring of blood glucose 1 to 2 times a day, especially if they are feeling any case of hypoglycemia, then without delay they should check their blood glucose level. In cases of very high risk group or high risk group, frequency of SMG several times a day should be done to avoid the deadly hypoglycemic or hyperglycemic like DKA complications. All patients should break their fast, as I've already told, if the blood glucose is less than 70 or symptoms of hypoglycemia is there. Blood glucose level more than 300 needs to be monitored properly because they need medications on immediate basis, and symptoms of hypoglycemia or any kind of acute illness, they should break fast, because these are one of the important facts that can increase the mortality. So what are the medications? I'll be taking a few more times. Regarding metformin, daily dose remains unchanged. Immediate release once daily, take at iftar. BID dose, those who are taking twice daily, take at iftar and suhoor. Thrice daily, morning, combine in the afternoon, the prolonged release, and take at iftar. Acarbose, no dose medication is needed. In case of third daily dinner diet, no dose modification dose can be taken, can be with iftar or suhoor. Short-acting insulin secretagogue, that is thrice daily dosing, may be reduced or redistributed to two doses taken with iftar and suhoor. GLP-1 agonist, once appropriate dose titration has been achieved, no further dose modification is needed. DPP-4 inhibitors, no dose modification is needed. Regarding sulfonylurea, switch to newer sulfonylurea like glyclazide, glimepiride where possible. Glibenclamide should be avoided. Once daily, if you are advised, then take at iftar. Dose may be reduced in patients with good glycemic control. And BID dose, iftar dose remains unchanged. Suhoor dose may be reduced in patients with good glycemic control. SGLT2 inhibitors, no dose modifications. Dose should be taken with iftar. Extra clear fluid should be ingested during non-fasting period because the dehydration risk is high and should not be used in the elderly group, patients with renal impairment and hypertensive individuals or who those taking diuretics for other CVDs. Regarding insulin therapy, switch to insulin analog where possible, long or intermediate acting basal insulin once daily. Take preferably at iftar, reduce dose by 15 to 30% because patients are not going to take food for a very prolonged period. BID dose should be discouraged, and in that sense, take the usual morning dose at iftar and reduce evening dose by 50% and take at suhoor. Rapid or short-acting insulin, the bolus insulin, take normal dose at iftar, but omit the lunchtime dose, obviously because I'm not taking any meal. Premixed insulin, take normal dose at iftar. BID dose, take usual morning dose and reduce evening dose by 25 to 50%. And thrice daily dose, better to omit the afternoon dose. So dose titration should be performed every 3 days and dose adjustment made according to the blood glucose level. This is a chart you can see the fasting glucose, then PP glucose and the random glucose and how you can reduce the dose. In pre-iftar, the basal insulin, if you have a symptoms of hypoglycemia, then better not to take. If you are not having your blood glucose in the normal range, you are taking in the same dose, continue. If it is decreased, then reduce by 4 units to 2 units, depending upon your blood glucose level. You have to carry the chart and you have to consult with your physician so that the dose modification can be done properly. Changes to premixed insulin during Ramadan is very important. So once daily dosing, in those patients, take normal dose at iftar. Twice daily, take normal dose at iftar and reduce the evening dose by 20 to 50%. 3 times daily dosing, omit the afternoon dose. So these are one of the few important things that you have to remember whenever you are taking insulin because the prolonged period of fasting may give rise to hypoglycemia. So to summarize, many individuals on multiple anti-diabetic agents have a long duration of diabetes. Multiple comorbidities and renal impairment are there. Hence, they are at high risk of hypoglycemia when fasting during Ramadan. Individuals with type 2 diabetes on 3 or more anti-diabetic agents who fast during Ramadan should receive counseling and comprehensive advice on diet, lifestyle, and drug dose modifications prior to Ramadan. Individuals on 3 or more drug combinations, especially those on both insulin and sulfonylurea, should be considered at an increased risk of hypoglycemia. An approximate 25 to 50% reduction in the dose of insulin is advised, depending on the subsequent risk score after risk stratification. A reduction in the dose of sulfonylurea is also advocated in these individuals. Newer technologies, including continuous glucose monitoring and activity monitoring, need to be harnessed through artificial intelligence to reduce the risk of hypoglycemia in people with diabetes that are on multiple anti-diabetic agents and fast during Ramadan. Management of diabetes among elderly when fasting during Ramadan, the medications and regimen should be properly checked. SMBG, that is the self-monitoring of blood glucose, should be done. The diet modification should be done. The timing of medication has to be managed and physical activity level should be curtailed but not halted during the fasting hours. So lower proportions of elderly individuals fast than their younger counterparts. Diabetes-related complications such as hypoglycemia and hyperglycemia can be more frequent in elderly individuals than in younger ones. Greater and more careful planning are required during this period of fasting. There must be a greater emphasis on self-monitoring of blood glucose. Anti-diabetic drugs with lower risk of hypoglycemia are preferred in elderly individuals. And there is a significant need for more research into the elderly individuals with type 1 as well as type 2 and differing comorbidities that fast during Ramadan. So monitoring of blood glucose during Ramadan is very much important that I have been telling you. The SMBG, self-monitoring of blood glucose, is the most important tool to guide whether you are suffering from hypoglycemia or hyperglycemia. Role of technology is there. We have a teleconsultation, telemedicine, telemonitoring have all been identified as a very effective method. You can consult with your physicians at the same time can deliver the reports that you are checking at your home, and that can guide you to prevent some hypoglycemic or hyperglycemic episodes. The rising prevalence of diabetes in the Muslim population, combined with high numbers that participate in fasting, creates a pressing need for effective guidance for the management of diabetes during Ramadan. But this approach is very much individualized, and practical guidelines have been designed to provide the healthcare physicians with background and practical information in order to optimize the care for patients with diabetes who plan to fast during Ramadan. Individualized treatment regimens is very much important, as I am telling. Education, communication, and accessibility are all very critical to the success of guidance provided in these guidelines to prevent mortalities as well as morbidities. And ultimately, obviously, more research is required, increase understanding of the safety of diabetes and Ramadan. At the same time, uh, I wish all the good health to those who fast during Ramadan. Stay safe, stay protected. Thank you.